Good morning. We'll go ahead and get started. Today, it's my distinct pleasure, as well as the rest of our division, to introduce Dr. Alexander Gibbons, our second-year pediatric surgery fellow at Phoenix Children's. Dr. Gibbons earned his medical degree from Case Western Reserve University School of Medicine in 2016, where he also completed a master's degree in applied anatomy. He went on to complete general surgery residency at the Cleveland Clinic, graduating in 2023. He subsequently completed an additional fetal surgery fellowship year at Cincinnati Children's Hospital in 2024, and is now completing his pediatric surgery fellowship here, and soon will be graduating and then heading to Charleston, South Carolina. During dedicated research time, he authored more than 15 peer-reviewed manuscripts and textbook chapters, delivered numerous national presentations at national and international meetings, and contributed innovational educational media, including videos and infographics, to enhance surgical learning. Dr. Gibbons has a particular passion for fetal intervention, a field that demands not only technical excellence, but also thoughtful collaboration across disciplines. In every sense, Dr. Gibbons embodies the qualities we strive to cultivate in pediatric surgery. We are fortunate to have him as part of our program and look forward to the impact he will continue to make in our field. Please join me in welcoming Dr. Alexander Gibbons.
Well, thank you very much for that warm introduction. It's been an absolute honor and pleasure to have done my training here. Today I'll be talking with you about fetal surgical interventions and specifically a lot of fetoscopy. So this is going to be a womb with a view. And for my kids who are here in the audience, thank you very much. This is going to be about as long as Mass, but with probably slightly less singing. So if anyone's interested in the singing side, though, I'll be graduating with a karaoke party. To help keep the kids' attention, though, just be on the lookout for the Grim Reaper. When you see him, just give a shout. Okay. For my disclosures, I have no disclosures. So for the learning objectives for today, I'm going to briefly overview the history of fetal surgery, kind of how this field first developed and some of the landmark moments. I'll then kind of help us understand the workup for different disease processes that are the most common candidates for fetal intervention, at least the ones that I saw during my time in fetal surgery fellowship. Those being twin-twin transfusion syndrome, or TTTS, myelomeningocele, or MMC, congenital diaphragmatic hernia, CDH. And then we'll discuss the interventions that are available for those disease processes and their most common complications. So those interventions for TTTS, it's called selective fetoscopic laser photocoagulation, or SFLP. There's repair of MMC that can be done open or fetoscopically. And there's also, for CDH, fetal endotracheal occlusion, or FETO. So with kind of that overview, let's start at the very beginning. Some say it's a very good place to start. So in the 1960s is where we kind of had the first fetal interventions, and those being for the fetal transfusion. This is in 1963 at the same time that the first Beatles album was published. And this was specifically for immune hydrops, secondary to RH incompatibility. And there were kind of two different ways that they developed interventions for this technique almost simultaneously, those being open and percutaneous. For the open, it involved a maternal laparotomy and then hysterotomy with cannulation of the fetal saphenous vein or a vessel on the placenta, and therein they would do a partial exchange transfusion. For the percutaneous technique, they somewhat blindly inserted a needle into the amnion. They would infuse some contrast into there. They would allow some time for the fetus to swallow the contrast, and then it would percolate. And then they would have an idea fluoroscopically of where the fetal abdomen was, and they would then use that as guidance to impale the umbilical vein, and then do the partial exchange transfusion that way. So it was definitely complicated, but they saw that they took something that was essentially 100% perinatal mortality and had an intervention that would then save the fetus's life. So that is kind of one of the tenets for fetal surgery moving forward, is that there's kind of no effective treatment postnatally for it. Also, something that we kind of will see as a theme throughout is that the open approach had higher rates of preterm labor and other complications. In the 1970s, though, there was a period of relative quiescence for the advancement of fetal surgical techniques. Fetoscopy, which had been kind of also pioneered in the 1960s and which aided in both diagnostic purposes and then visualization of that umbilical vein, was replaced by ultrasound, which was not invasive, as this kind of really became common ground in obstetrics. The fetal surgical techniques kind of had a pause. We just kind of let it be for this decade. But moving forward into the 1980s and 1990s, this was really kind of the era of first pioneering open fetal surgical techniques. And they had early challenges that they tried to address to kind of have an accurate diagnosis and defining disease processes that would be kind of amenable to a fetal intervention, while also combating the high frequency of preterm labor and delivery that were subsequent complications of those interventions. This was really a thrilling time. In 1982, it was the first meeting of the International Fetal Medicine and Surgery Society, or IFMSS. And it was at this meeting that they published a consensus guideline for kind of basic requirements for considering new fetal surgical interventions. And these tenets really kind of helped have an ethical and vigorous scientific framework for moving forward with stuff that was obviously kind of ethically and emotionally charged and operating on a fetus. And so they, in 1982, that same year that they had this meeting and published those guidelines, were the first two case reports for open fetal surgical interventions, those being for congenital hydronephrosis and congenital hydrocephalus. In the subsequent decade, there are other disease processes that they developed interventions for. There's a whole flood of them for these future giants in the field. In 1990 is congenital diaphragmatic hernia, CPAM, and twin-twin transfusion syndrome. These were all the kind of first interventions. Case reports for these interventions were published in 1990. And then throughout the rest of the 90s, there is kind of a blur. They had interventions also for sacrococcygeal teratoma and the first for myelomeningocele in 1997. And those tenets of fetal surgery that I alluded to, I just wanted to kind of specifically elucidate them because they were very important in developing this ethical and scientific framework. And this is Michael Harrison. He's basically the father for the field for fetal surgery. And he's the first author for these guidelines and continued to kind of help champion and pioneer the field. So the first is that it should be a simple structural defect that interferes with organ development, but that would allow for development to proceed normally if it was corrected in utero. It had to be a singleton pregnancy without other structural or genetic anomalies. There was going to be complications enough with a single fetus without anything else going on. They felt that natural history should be known and that intervention should have a possibility of benefit without any effective postnatal therapy. Felt that the intervention should already have been able to be demonstrated to be viable in animal models. They didn't want to be doing the first experiments on a human fetus. And so a lot of that time in the 1970s and 80s where their relative quiescence was dedicated to developing animal models for these different disease processes that they then were able to demonstrate its effective, and should be able to safely move on to human intervention. They wanted to make sure that they had an idea of the natural history of the disease and that they had ways to diagnose it and follow it to make sure that it wasn't too mild and not need an intervention, or too severe where an intervention would be futile. It felt the family had to be aware of the risk and benefit and agreed to long-term follow-up. So they saw not only the results for the pregnancy, but for the lifetime that they were trying to save. Crucially, it felt needed to be a multidisciplinary discussion where a team involving a maternal fetal medicine doctor, pediatric surgeon, and a neonatologist all had to meet and agree on the treatment plan. And they needed to have access to a high-level obstetric unit for the mother and a NICU for the baby thereafter. So, a lot of these tenets would somewhat be bent in the coming decades, but especially in the first decade and a half, it was very important to have this framework, and so that the field could be advanced safely and ethically and with buy-in from all the participants. That then laid the groundwork for the modern era. In the 2000s, we saw kind of a revitalization of fetoscopy. In 2003, kind of as is this it, there's the first publication for fetoscopic tracheal occlusion with a balloon for CDH. And the fetoscopy train kept rolling. We just had to smile as the first randomized control trial in 2004 was published by the Eurofetus group, the first RCT in fetal surgery, where they compared laser photocoagulation to what had previously been the standard of serial amnioreductions for twin-twin transfusion syndrome. By 2007, it was clear that people were going gaga for fetoscopy, and we had the first NIH trial that was also published to compare SFLP to amnioreduction. And then in 2010, we could say, that this is happening now. We had a large prospective observational trial for FETO as well, and that laid the groundwork for subsequent randomized control trials that we'll talk about in a little bit more detail later. 2010 was the, or 2011 was the publication for the MOMS trial. And so this decade really then led to a boom in the field of fetal surgery. This was kind of the throne, the gold standard for randomized control trials for fetal surgery. And the publication of the MOMS trial and the kind of reaction thereafter has greatly impacted the field since. And we'll talk about that in much more detail later. And then by 2016, took a chance on performing fetoscopic intervention for MMZ repair as well. This was the first publication for describing the fetoscopic repair in a large series. So with this kind of groundwork for the history laid out, kind of talk about some of those common disease processes, the first being twin-twin transfusion syndrome. So this occurs in about 10% of monochorionic diamniotic twin pregnancies. So this is one where the twins are in separate amniotic sacs, but they share placental blood supply. And it's about 1/3 of spontaneous twin pregnancies. And because of the risk for development of twin transfusion syndrome, these pregnancies need to be monitored every fortnight with ultrasound, starting at 16 weeks gestational age. And the way that this happens, vascular anastomoses normally exist in these pregnancies, but twins should be little communists. They need to share their blood supply equally. And so even though these vascular anastomoses exist, there's an equal distribution of blood flow across them normally. And these connections can be unidirectional, either arteriovenous or veno-arterial, or bidirectional, arterio-arterial or veno-venous. But they allow for kind of that blood flow across the placenta or the vascular equator. But in twin-twin transfusion syndrome, these anastomoses become unbalanced. There's a donor twin giving to the recipient twin, and there's negative sequela for both twins. And the perinatal mortality is 60 to 100% if untreated. And so this certainly kind of fits the framework of having a disease process that has no effective postnatal treatment, and therefore kind of ripe for an intervention. Some of those sequelae of the unbalanced transfusion is an illustration from my residency alma mater. You can kind of see here for the donor, which is the smaller twin, Because of decreased blood flow to that twin, there's decreased blood flow to their kidneys. They make less fetal urine and therefore develop oligohydramnios and the subsequent Potter sequence therein. They also will have less blood flow generally and can develop intrauterine growth restriction compared to the recipient twin. Because they're essentially pumping for themselves and contributing to the recipient twin, they can develop a high output cardiac failure. And that can lead to both cerebral ischemia and hydrops fetalis, which is problematic there, and not just for the twin, but mothers at risk for developing Muir syndrome. And so if hydrops is seen, then this is truly an emergent diagnosis. And then the twin can die as well with intrauterine fetal demise. For the recipient twin, they also have negative sequela. They are seeing too much blood flow. They will create increased fetal urine and develop polyhydramnios, and that can cause issues with preterm labor and delivery. Because they have increased blood flow, they also develop cardiomegaly. And not only do they have increased blood volume, but they also have increased red blood cells. They can develop polycythemia, which is then thought to contribute to cerebral ischemia in their recipient twin. They too, with their volume overload, can develop hydrops and also intrauterine fetal demise. So problem for both the twins. But how do we know when to intervene on it? Obviously, not every twin is going to be presenting with hydrops. So there's what's called the Quintero staging system, where they are able to make this diagnosis and then decide when an intervention should be done. So in stage 1, you can measure in the twins with ultrasound what's called the maximum vertical pocket, or MVP. And in order to have oligohydramnios in the donor twin, that MVP has to be less than 2 centimeters, and polyhydramnios in the recipient twins greater than 8 centimeters. There can't be any evidence of fetal distress or any of the other things that we'll see in the later staging, and there should be normal Doppler signals in the umbilical artery and vein for both twins. And so here's an example of that oligo in the donor and poly in the recipient. For stage 2, the donor bladder is not visible. So you can, identify where the umbilical vessels are, and the fetal bladder should be in close proximity to that. And because of the decreased blood flow to the kidneys and that decreased production of urine, the bladder is not visible. And at stage 2 is when we would recommend intervention with the laser photocoagulation. The Doppler signals themselves, though, are still normal in stage 2. In stage 3, they become abnormal. They have an absent or reverse end diastolic velocity. And in Cincinnati, we would also include any evidence of any fetal cardiomyopathy. So all these patients would also get fetal echocardiograms. And if there's any evidence of fetal cardiomyopathy, that would, even if they had a visible bladder, automatically upstage them then to a stage 3. And they had subgrading based on the severity of the cardiomyopathy on fetal echo. In stage 4, there's presence of fetal hydrops in one or both twins. We talked about kind of the pathophysiology for how that would happen. Just as a refresher for what hydrops is or how you diagnose it, there's essentially 4 fetal compartments where fluid can accumulate, and in hydrops, there's evidence of fluid accumulation in at least 2 of those. And so those are the skin, the thorax, the abdomen, or the brain. So any development of any fetal fluid accumulation in any of those. And then stage 5 is intrauterine demise. It can be one or both twins. So what do? We can just watch and wait sometimes. So in stage 1, without additional complicating factors, can monitor and see if there's any progression. But normally these twins, as I mentioned already, are getting monitored every fortnight. But when there's any evidence of stage 1 twin-twin transfusion syndrome, that will decrease to weekly fetal surveillance, as about 60% of these will then progress to stage 2 or above. And they looked at this, is this a safe option to do in a 2021 multi-center randomized control trial on both sides of the Atlantic, looking at stage 1 patients that were between 16 and 26 weeks of gestational age, so within the target for intervention for a laser. And they had to have a cervix length greater than 15 millimeters. If they had a short cervix, that put them at increased risk for preterm labor, and so they weren't a candidate. And they had to have access to a surgical site within 48 hours, so if they saw any progression, they could get timely intervention. And they found that there was no difference in intact survival, 77% in the expectant management and 88% in the kind of early laser arm. or any severe neurologic morbidity at 6-month follow-up at 4.6% versus 2.6%. So no statistically significant difference between the two groups. Of note, though, as I mentioned already, that known progression, they saw 59% of the pregnancies in that expectant managed group did require a rescue surgery for that progression, but there weren't any increased negative sequela by having the later intervention instead of a somewhat prophylactic early intervention. So what were other treatment options? Historically, we'd have amnioreduction. This would be done serially. You would take a needle and stick it into the recipient's amnion and do a reduction. This was historically used as the primary treatment, but in order to reduce polyhydramnios symptoms and reduce the risk for preterm labor, but it would typically require multiple treatments as the fluid would usually reaccumulate. This can still be used as a temporizing measure if in a remote location without access to SFLP. But really the gold standard is the laser photocoagulation at this point. As I said, we offer it to stage 2 to 4 twin transfusion syndrome patients between 16 and 26 weeks. If it's later than that or earlier than that, it can be on a case-by-case basis. But toward the later end, it would then be kind of at the point of viability and could be delivered if needed. The goal is to eliminate all the vascular anastomoses and thereby convert the placental circulation to a dichorionic. And we do this with ultrasound guidance. We map out the placenta and then percutaneously access the amnion. Some people will use a needle and then a sheath to go in. Some will just poke with the fetoscope. But either way, percutaneously access the amnion. If it's posterior, it's a straighter shot for you. But if the placenta is anterior, then you have to use a curved fetoscope to safely access the amnion of the recipient twin. If you've used the sheath, you then use a Seldinger technique or the needle, place the sheath and then advance the fetoscope into the amnion. And then systematically survey and document all the vascular anastomoses so you know what you're targeting. And then you use a laser through the port in the fetoscope to photocoagulate all those anastomoses that you've documented. Thereafter, you still are going to do the amnio reduction of the recipient twin. So it's not laser alone, that amnio reduction is still important. And usually you're always monitoring with an ultrasound during any fetal intervention. The MFM is there to help with that. And the goal is to reduce to have that MVP be to 5 to 6 centimeters. And this is a procedure that can be performed just with a local anesthetic. So minimal risk to the mom. There's kind of a dearth of videos that show actual fetoscopic laser photocoagulation, but this is one that I found from which I have no affiliation.
The first key step to successful laser surgery is gaining access to the uterine sac of the recipient. This is done in most of the times under local anesthetic. Once we're in the sac of the recipient, we will identify the cord insertion of the recipient, as you see here in the middle of the picture. And from there, we will follow the vessels that run on the placenta and selectively identify those that connect with the donor twin that you can see now here. The white line that now comes into the image is the membrane in the donor twin that's draped over the placenta because that baby has no fluid left. Once we identify these vessels, we will then bring in the laser fiber and coagulate them until they're completely white, so we're sure there is no blood flow between the two twins. And then at the end of the procedure, we will also laser along the line of the vascular equator, which is the natural dividing line between the two twins, and then drain the fluid in the sac of the recipient so that it is normal. Typically, the fluid and bladder filling returns back to normal within 2 weeks after the laser procedure, and the patients can return to the referring obstetricians.
So those are always fun procedures to do. We come up with kind of unique names for each of the anastomoses that we saw so that there'd be a way to then remember to go back and find all of them. So one person would be going through and be like, oh, that looks like a witch's hat. And they would write that down. And then we would go back and make sure that we got the witch's hat with the photocoagulation. And how do we know that this is more effective than amnio reduction? So I mentioned that 2004 randomized control trial where we compared amnio reduction alone under ultrasound guidance, and it would be repeated as needed to laser photocoagulation with the amnio reduction. There's kind of a recurring theme here too with these randomized controlled trials in that they had to conclude it early at interim analysis due to significant benefit in the treatment arm. They saw survival at least one twin at birth in 76% of the laser arm versus 56% of the amnioreduction arm. And then at 6 months, still 76% survival for the laser versus 51 for the amnioreduction. And the number of patients without a major neurologic complication at 6 months was also statistically better in the laser group. There are no significantly different complications between the groups either. And since this study was published, it's been 2 decades, the modern high volume centers have only continued to improve. Where now at least one survivor is the case in the vast majority, like more than 90%, and both twins survive up to 70%. So almost as much as we're having at least one survivor in the randomized control trial. But obviously every procedure that we do has risk associated with it, so we have to monitor for these potential complications. After the initial treatment, they'll get weekly ultrasounds for at least 6 weeks and then bi-weekly until delivery. And what we're looking for there is for recurrent twin-twin transfusion syndrome, which can happen about 10% of the time, or development of what's called twin anemia polycythemia sequence, or TAPS, where there's still smaller anastomoses that exist. The kind of volume is similar between the two twins, but there's still an unequal share of the red blood cells. And so one twin will become anemic and the other polycythemic. One way it's thought that this is due to kind of smaller vascular anastomoses that weren't visible at the time of fetoscopy. And so one other option, in which was alluded to in that video, is what's called Solomonization. This is Solomon the Wise, the biblical story where the two women claim to have the both claim that the baby was theirs, and so they threatened to cut the baby in half and give one to each of them, and saw the reaction for both of them to see who was the real mother. So this procedure is not as invasive as like a hemicorpectomy would have been, but it is essentially using kind of along that vascular equator, photocoagulating all along it, so that those smaller anastomoses that can't be seen are then also coagulated. And they found with that there was a decreased rate of both recurrent twin-twin transfusion syndrome as well as this, TAPS in the Solomonization group. But other studies have shown there's a trade-off for this. Since you're photocoagulating a larger surface area for the placenta, there's an increased rate for placental abruption and also an increased risk for septostomy, the area between the two amnions. And so then they're converting a monochorionic diamniotic pregnancy to a diamniotic monochorionic pregnancy. And the monoamniotic aspect of it is has risk associated with it. The cord from one twin can entangle with the other, and so there's increased risk of mortality of one or both twins if there's a monoamniotic pregnancy. With dual survival, the aim is for a delivery at 34 to 36 weeks gestational age. But if there's only a single survivor, the aim is to deliver near term. However, after fetal intervention and with a twin pregnancy, the mean gestational age of delivery is 30 to 31 weeks. One of the kind of common complications that we see in any fetal intervention is what's called chorioamniotic separation, which you can see on ultrasound here. And there's a visualization here where the chorion on the uterus is separated from the amniotic sac, the bag of waters. And this kind of separation can worsen over time, leading thereafter to preterm premature rupture of membranes and preterm labor and delivery. So in the SFLP patients, we see increased rate of chorioamniotic separation, PPROM, which is the preterm premature rupture of membranes, and preterm labor and delivery. So as I said, the mean gestational age is 30 to 31 weeks. And in about 1/5 of those, it's kind of extreme prematurity prior to 28 weeks. And so problems that our neonatology colleagues are going to help us postnatally. But again, this was a disease process with 60 to 100% perinatal mortality without an intervention. So the risks, I think, are still outweigh the benefit, or the benefits still outweigh the risks. So moving on then from twin-twin transfusion syndrome to MMC. This is the most common central nervous system anomaly that's compatible with life. at about 3.4 per 10,000 live births. That's even after kind of folate supplementation is the norm. And this is an open neural tube defect. It's almost always associated also with a KRA2 malformation. And there's thought to be kind of multiple insults or hits that lead to the dysfunction that we see in motor sensory nerves and the bowel and bladder dysfunction. The first is the failure of that neural tube to close itself. That incomplete closure also results in a malformation of the spinal cord at and distal to the defect. And so that's going to cause some dysfunction in and of itself. But then that open neural tube is going to be exposed both to amniotic fluid and mechanical stress for the duration of the pregnancy. That's going to cause continued injury to the exposed spinal cord. And there's also leakage of the central cerebrospinal fluid from that open defect, which results in decreased distension of the fetal ventricle and eventually hindbrain herniation and hydrocephalus in the fetus. And so the goal of prenatal repair is to minimize the impact of that second hit. And this is also kind of veering off a little bit from those tenets of fetal surgical intervention that I mentioned earlier, and that there is an effective postnatal therapy for this. It can do an MMC repair after birth. But in animal models, they were seeing that there was a benefit to the fetal repair. And so even though, you know, the mother would be undergoing a risk with the surgical intervention without a risk of death to the fetus with the disease process, the benefit that they saw, they wanted to investigate further. And so they did what's called MOMS. Here's some moms who are important to me. Got my mom here, my wife, who's mother to my children, and her mother, and then my sisters and sister-in-law who are mothers or godmothers themselves. But for moms in fetal surgery, it's the management of myelomeningocele study. This is a multi-center randomized controlled trial that compared postnatal repair to fetal repair. And there were kind of some very key decisions in planning for this study that I don't know if we'll be able to kind of catch lightning in a bottle again. But agreed that only 3 centers in North America would perform the repair, and those were UCSF, Vanderbilt, CHOP. All other centers in North America agreed to have a moratorium on MMC repair and refer all their patients initially for evaluation to a 4th center that would then distribute to the closest of these 3 centers. And they also standardized the surgical technique across all of them. The criteria are worth kind of going into detail because these are still the criteria that we use when offering an intervention today. Those being that it's a singleton pregnancy, the upper border for that defect should be between T1 and S1. There should be evidence of hindbrain herniation. The intervention should be able to be carried out between 19 and 26 weeks of gestational age. You need to have a normal karyotype, live in the US, and have a mother has to be an adult. For exclusion, there couldn't be any other unrelated fetal anomaly. Again, kind of going back to those tenets that we talked about earlier, there couldn't be any evidence of severe kyphosis. They couldn't be at risk of preterm birth with having had a history of preterm birth or a short cervix. There couldn't be any evidence of placental abruption. The BMI had to be under 35, and they couldn't have any previous hysterotomy. And so this standardized surgical technique involves general anesthetic to the mother with an indwelling epidural. So already greater risk for the mother compared to the local that we do for SFLP. They then would extracorporealize the uterus with a Van Steel incision and use an ultrasound directly on the uterus to visualize the defect and the placenta. They would then plan where they wanted the hysterotomy to be and reposition the fetus so that the defect would be right at that planned hysterotomy. Then place stay sutures through the uterus to attack the amnion to the uterus and hopefully help reduce that risk for chorioamniotic separation, and then sharply enter the uterus between those stay sutures. And then use a uterine stapler with absorbable staples to create a 6 to 8 centimeter hysterotomy. Then with the fetus exposed, they would give a fetal cocktail intramuscularly, which involved fentanyl and vicuronium, and then dissect out the neural placode. Once that was released, close the dura either primarily or with patch, and then close the skin defect over top of it, again, either primarily or with alloderm. And then as they were closing, they would close the uterus in layers, and prior to closure to the first layer, would refill the amniotic fluid that would inevitably be lost during the open hysterotomy with warmed LR to help get the MVP back up. Here's some illustrations from the moms that show the phanencial incision, the hysterotomy with the staplers with the exposure to the neural plaque code, and then they would dissect this out, free it up, and then once that was freed, would close the defect. What did they find? Again, they had to end the study early due to interim analysis showing improved efficacy in the fetal intervention arm. And they found their primary outcome was a composite of either fetal or neonatal death or a need for fetal shunt prior to 12 months of age. And they found that for this primary outcome, 68% of patients who underwent a fetal repair either had the perinatal death or needed a shunt within 12 months versus 98% in the postnatal treatment. Specifically for shunt placement, that also was statistically significantly better in the fetal intervention group, with 40% of the patients in the fetal group needing a shunt at 12 months versus 82% in the postnatal repair. Their other primary outcome was kind of to assess neurologic function, and they did a composite of what's called the Bailey Mental Development Index, as well as a score where they looked at where their functional deficit still was compared to what it would have expected to be based on their anatomic level of the lesion. And they looked at that when they were toddlers at 30 months of age. And that was also significantly better in the prenatal surgery group. So not only did they need shunts less often, but they also had developmentally functionally better. However, in the fetal intervention group, they had significantly higher rates of preterm labor prior to 35 weeks in 46% of patients, and prior to 30 weeks in 13% of patients. They also had much higher rates of spontaneous rupture of membranes, and based on the preterm labor, that was typically PPROM in the fetal intervention group, and a high rate of chorioamniotic separation. So instrumenting the uterus is going to have sequelae, and they saw that as some of the complications. Additionally, with the hysterotomy, they would always deliver these fetuses via C-section thereafter. They would inspect the area where they had closed the uterus before, and they had about a 10% rate of uterine dehiscence. And so all subsequent pregnancies would require a C-section due to risk for uterine rupture. They have also subsequently followed up with long-term results, MOMS 2, the momming. This is a follow-up cohort study of 161 patients from that same randomized group. And this was now the cohort had reached school age. And they wanted to evaluate kind of adaptive behaviors between the groups to see kind of functionally what they were seeing long-term. And they didn't see any kind of statistically significant difference in behaviors requiring some adaptation, but they did see a trend for decreased use of orthotics in the prenatal repair group at 29% versus 11%, and lower rates of hindbrain herniation, still 60% versus 87%. And the kind of reduction in shunt placement that had been seen at 12 months was still evident even when they were school-age children, 49% versus 85%. And those who did need shunts, there were fewer revisions that were needed for them. So had some benefit, long-term, and they're going to be doing a MOMS 3 as well, and continue to follow this cohort long-term. But with those negative sequelae with the open repair, is fetoscopic repair possible? And so then a desire to kind of avoid these sequelae and complications of the hysterotomy, developed a fetoscopic technique. This still requires general anesthesia with the maternal laparotomy, but once the uterus is extracorporealized, we then place ports with ultrasound guidance between box stitches, again with the goal of trying to tack that amnion up to the uterus. And then do an amnio reduction, and then insufflate the uterus with warmed and humidified CO2, administer the fetal cocktail still, and then similarly dissect out the placode, close the dura and the skin, and then prior to removing the ports, fill the uterus with warmed LR again. And this is a video from Colombia where we can kind of see
box
so here you can see the extra. Can see Is there like?
There you go.
Okay.
Go up there, hit the box. Excellent.
Yeah. Just putting my reverse laparoscopic skills to use.
Is insufflated with carbon dioxide. 2 additional ports are placed under direct visualization. A standard intramuscular fetal cocktail of vecuronium.
See about going to video here. There we go. It's better.
Working, not performed in our fetoscopic technique. While some postnatal repairs may include.
I just wanted to kind of highlight what this looked like here. So I'm dissecting out that
Skin flaps are mobilized to
And then once
prepare
it's
for
dissected out,
tension-free closure.
yeah, in order to get tension free, they have some.
Transitional epithelium is excised. When hemostasis is required, monopolar cautery scissors are used sparingly at a low power setting of 10 watts for superficial bleeding points away from the placode. Tamponade and irrigation are preferred whenever possible, and direct contact with neural tissue is avoided. A Duragen collagen matrix is placed as an overlaid dural substitute and is not sutured to native dura in our technique. Water tightness is achieved through subsequent multilayer closure. A central stitch is then placed to approximate the skin edges and relieve tension prior to final closure. The skin is closed using a running 4-0 V-lock suture, creating a watertight repair. Here we show postoperative images from days of life 1 and 3 demonstrating durable watertight closure with no cerebrospinal fluid leak.
And then I just wanted to also show what the uterus looked like with exposure in the ports. Find that here.
Placed. The first port is placed.
So you can see here the uterus is still extraportalized. Mom still is general anesthetic with a laparotomy, but then we have placed those ports between box stitches to reduce that risk of amnio or amniotic separation. All right. What do they find in terms of comparing fetoscopic to open MMC repair? There's no randomized control trials at this point, but there are several cohort studies and registry analyses. The largest single center study comes from Texas Children's, Dr. Nutrika's alma mater for fellowship, where they compared 100 fetoscopic repairs to 41 open and 59 postnatal. They kind of deferred the method that the mother wanted to undergo for repair after counseling. And then they followed up their outcomes. They confirmed kind of the improved neurologic outcomes seen in moms with improved hydrocephalus treatment at 12 months in both the fetal, fetoscopic and open fetal repair, and similar benefits for ambulation at 30 months. But they found that the fetoscopic approach had an improved median gestational age at term versus still preterm, improved uterine healing when they inspected the uterus, and higher rates of vaginal delivery. So whereas both the open fetal repair and the postnatal repair are mandatory C-sections, with fetoscopic repair, more than half of these women were able to have a vaginal delivery, and therefore also did not need subsequent C-section in the future. Fetoscopic, though, had worsened rates of chorioamniotic separation. The box stitches that they placed are evidently not as effective as closing the uterus with the open technique, and significantly longer operative times with more than an hour and a half difference between them. But overall, I think still an area that would benefit from a randomized control trial, but this is some pretty compelling data, and at a lot of centers now, will always offer, like at Cincinnati, would always offer fetoscopic and open MMC repair, but the parents would almost always pick the fetoscopic option. Final disease process I'm going to go through here is congenital diaphragmatic hernia, one of pediatric surgeons' favorites. This happens in about 1 per 4,000 births. 80% are left-sided, and it results in both pulmonary hypoplasia and pulmonary hypertension. But there's about a 30% result in these pregnancies where there's termination, intrauterine fetal demise, or stillbirth. So You guys remember what you're supposed to do? This is you found the hidden mortality of CDH. So was really kind of one of the main impetuses for Dr. Harrison to investigate the field. He'd spent time after his residency in Norway, in Oslo, and had found they had a much better registry there for their CDH diagnoses, and he'd seen that 50% of them, were not making it to be reported in the perinatal outcomes. So he then, was motivated to find an intervention that would help decrease this hidden mortality. So this is a diagnosis that's typically picked up at 20 weeks on the anatomy scan. That ultrasound remains kind of the mainstay for diagnosis and prognostication, can determine whether the liver is up or down, which is an important prognostic factor, as well as develop what's called the O to E LHR, or observed to expected lung-head ratio. And what this involves is with ultrasound, you find the 4-chamber view of the heart. And then normally it will end up looking like this in that view. And you can trace out the surface area or the circumference for the lung, and then compute what the resultant lung volume would be for that, or for the lung component of the lung-head ratio. Oh, sorry. So tracing out the right lung. It's the contralateral lung that you're measuring, typically with the right. But then with CDH, you're going to have some impingement on that with resultant pulmonary hypoplasia. And so can calculate what that lung circumference is, and then compare it to the head circumference. There's a ratio, there's been millions of ultrasounds done. There's a nomogram to have what the expected lung-head ratio should be for any point in development. Since it's not going to be, they're not going to grow equally, but the ratio should be able to follow this nomogram. And so you can measure the observed lung-head ratio and compare it to the expected. And that helps us prognosticate for severity of CDH, where the mild CDH should be greater than 45% for that O to E LHR. This is about 40% of the cases that we see with an 85% survival. Moderate is 26 to 35% for the ODE. This is about 45% of the cases that we see with the 50% survival. Severe is 15 to 25% ODE. This is about 14% of cases that we see, but much worse survival with only 15 to 20%. And extreme is less than 15%. Fortunately, it's only about 1% of cases that we see, but with less than 5% survival. Other kind of aids for prenatal diagnosis include fetal MRI, where we can calculate the total fetal lung volume and the percent predicted lung volume. There's not as well studied at this point as compared to the ODE-LHR, but roughly like a 35% PPLV corresponds to a severe CDH with the ODE. You can also calculate the percentage of the liver that's up, with a greater than 20% portion of the liver being associated with increased mortality. And it allows for evaluation of other anatomic abnormalities, since about 40% patients with CDH will have at least one other anomaly. So what are some fetal interventions that we can do for this? Early kind of trials involved doing in utero repair, but the results for that showed worse outcomes. And so instead, kind of find ways to help combat the pulmonary hypoplasia. And so this is what fetal endotracheal occlusion is all about. This is offered to patients with severe CDH and is done between 27 and 30 weeks gestational age. Involves percutaneous access to the uterus, so again, it can be done under local anesthetic, and involves intubating the fetus with the fetoscope, and then deploy a balloon to occlude the trachea. So similar to kind of old cartoons where stepping on the garden hose and things upstream kind of get dilated. The idea here is that the pulmonary fluid that the lung creates, it usually contributes to about 10% of the amniotic fluid, other 90% being fetal urine. So that 10% is now occluded, can't leave the lungs, and has some pressure to kind of push back against the abdominal viscera that are causing the pulmonary hypoplasia. Once the balloon is in, obviously a balloon including the trachea is not compatible after birth. And so plan to remove the balloon between 34 and 35 weeks gestational age. But if developed preterm labor, which we know from the other studies is high risk for any fetal intervention, they would need an urgent exit, which is ex-partum intrauterine therapy for balloon removal. So while the fetus is still connected to the placenta, but has been removed from the uterus and still has that placental blood supply, go in and pop the balloon. Fortunately, there's also a magnetic ball valve under study, so hopefully the increased instrumentation to get that balloon out will be less problematic. Essentially, have the mom walk around an MRI a bunch of times, and that will then have the magnetic ball valve decrease the fluid in the balloon, and therefore effectively pop it without another intervention. Otherwise, you have to either do it percutaneously, which is very challenging to find a window to pop the balloon. Only about 15 to 20% of the time is that able to be done, or do another fetoscopy to intubate the fetus again and pop the balloon. And obviously, both of those instrumentations of the uterus will increase your risk for the complications thereof. I have another video here, again from Hopkins, to show what a feto looks like.
To do this, we use a tiny camera that we guide past into the mouth and past the vocal cords of the baby into the trachea, which you can see here in the video. And once we have verified that we are in the correct anatomic position, the balloon is advanced from its deployment catheter and then inflated with normal saline. Once we have verified that the balloon is in its proper position, we can now detach the deployment catheter, and the balloon is left in place about 4 to 6 weeks. During this time, the lung fluid cannot escape, and therefore the lungs distend further and again reverse some of the problems that babies with congenital diaphragmatic hernia have due to lung immaturity after birth.
All right, so in order to study this, in Europe, they had the tracheal occlusion to accelerate lung growth trial, or total trial. And they had two kind of arms for this. One was for severe CDH, again, by the ODE-LHR. This is a multi-center randomized controlled trial in Europe with 40 patients in each arm. Again, was stopped early for efficacy. Intervention was between 27 and 30 weeks gestational age. And they found for survival with feto that it was significantly better, 40% compared to 15% in the traditional expectant management group. They also found, though, higher rates of PPROM with feto at 47% versus 11%, and preterm birth also higher with feto at 75% versus 29%. And so the median gestational age was 32 weeks versus almost 36 weeks. But they found, even with the greater rates of preterm labor and prematurity, that their outcomes were better in the feto group. They also had less ECMO utilization with feto, with 5% compared to 29%. I think in Europe, they utilize ECMO less frequently generally, and so that's something we'll talk about for the North American study. And there were 2 fetal deaths in the fetal arm. One was due to a laceration of the placenta at the time of the balloon puncture, and the other one was during an attempted exit to get the fetus out with preterm labor. They also had a moderate arm, so this was less severe. And they found that there was less benefit for this group as well. They had more patients in each arm since it didn't need to be stopped early for efficacy, with 98 in each arm. Intervention, though, they wanted to do later, and I think this is kind of a limitation to the study potentially, because they wanted to have reduced risk of the preterm labor known with fetal interventions. They wanted to have this more moderate disease group have a later intervention. So it was between 30 and 33 weeks gestational age. They found survival between the two groups was not statistically significant. There's maybe a trend towards improved survival in feto. But again, PPROM was higher, preterm birth was higher, the median gestational age was younger. And they had no difference in ECMO utilization. And they had 1 death in the feto arm due to a failed balloon removal. Essentially, from these 2 studies, the overall recommendation would be to consider feto in the severe CDH group, but not in the moderate group. But again, I think the limitation is that they did it with this kind of later gestational age, and therefore probably saw less benefit from the tracheal occlusion. And then there's also the NAFNet trial. This is for North America. Also a severe CDH trial. But instead of a randomized control trial, this was a comparative study in North America, and it was across 10 centers. So I think one of the kind of sequela of that moratorium from the moms was that now, those fetal intervention groups that didn't have experience during that decade of the moratorium were now kind of behind the 8 ball and having that experience. They didn't want to have that happen again. And so instead of only 3 centers, there were 10 centers that participated in this. They had 63 in the FETO and 43 in the expected management. Intervention was the same time frame, but they didn't see any statistically significant benefit of survival in FETO. You can see that our expected management in the North American arm is much, much higher than the European one, 15% versus 58%. And because of that improved survival in the expected management arm, there's then no difference statistically in the fetal arm. And similarly, had higher rates of PPROM in the fetal arm. Median gestational age was again younger. ECMO utilization was similar between the two, but they did have a trend towards a shorter ECMO duration in the fetal arm. So still kind of up to debate about the benefit for FETO, at least in North America, where we seem to have a better improved survival with expected management, potentially secondary to our greater use of ECMO compared to Europe. So in conclusion, fetal surgery has evolved considerably in the 40 years since. Fetal interventions can reverse otherwise fatal prenatal diagnoses. Benefits can be seen even in non-fatal conditions, can be harder, better, faster, stronger. But there are risks of any fetal intervention with CAS, PPROM, and preterm delivery being a bit too soon sometimes. So I'd just like to thank everyone again for inviting me to participate in Grand Rounds. I'd like to have some specific thank yous to the surgeons and APPs who have made this last 2 years so wonderful. My fantastic fellows, both senior and junior, who could not have made it through without, and my family, who has been supportive of me through this entire decade plus of training. My kids haven't known anything else, so I would not have been able to do it without them.
Okay.
Got a little bit of time for questions, so Dr. Ndrika.
So first of all, congratulations on an amazing talk and an amazing career. How do you think the impact of better survival for small babies is going to impact fetal surgery? So we're now seeing reasonable outcomes in 22-week preterm babies. Is that going to eventually eliminate the need for fetal surgery because we're just going to deliver that fetus, not bring the fetus?
I think that certainly is something that we'll have to consider, but I think also there'll be other disease processes that would not be able to be performed postnatally. There's some studies now for gene therapy as well, with either nanoparticles or viral vectors to administer essentially like splicer kind of sequences and help with gene therapy. So even as I think we see some of the improved benefits of perinatal with extreme prematurity, there'll be other disease processes where the techniques that we've developed in fetal surgery can then be applied to. And I think still, if CDH baby with severe disease is born at 22 weeks, they're not going to survive. So there'll still be a patient population that you're not going to want to induce a preterm delivery and would still benefit from a fetal intervention. And also for twin transfusion, those babies are all too small to be able to deliver that premature. So I think there'll still be plenty of interventions that both exist and will continue to develop with time. Dr. Badia?
Yeah, nice talk. I just, it's not really a question, but more of a comment. I just wanted to really just emphasize 2 points. Firstly, I think, Mike always points to the thing that really revolutionized this and changed the way he thought about this was the advent of fetal ultrasonography. So when my mom was pregnant with me, she did not have a fetal ultrasound. Probably every resident in this room, their mother had fetal ultrasound. So that's really what allowed them to identify these anatomical defects and start thinking about repairing them. And so that was just one point that Mike always made is a big deal. And just recently at our national meeting, Diana Farmer was Mike's longtime partner and is really a giant in the field in her own right. She just again expressed concern that these fetal interventions are born on the backs of mothers. And so there is essentially no benefit to the mother's health of these fetal interventions, only risk. And it's just really important to think about that very carefully. We start thinking about offering fetal intervention, because the benefit is only to the fetus. And if ever there was a vulnerable population in terms of being able to make informed decisions about their health, it would be, I think, a pregnant mother.
Absolutely, yeah, 100% agree with both those statements, particularly for the mother bearing all of the risk, especially for a disease process like myelomeningocele, where there is an option afterwards. You saw in that TCH study that there is still a not insignificant portion who elected to have the postnatal repair, and I think that's totally reasonable. And for at Cincinnati, my time there, any patient who is going to be considering a repair for fetoscopic or open fetal MMC had a minimum of 3 meetings with the entire, we call them teams meetings, where there'd always be a pediatric fetal surgeon, MFM, and a neonatologist present. Usually there would also frequently be some palliative care there, and they had to have a minimum of 3 meetings if they're going to be undergoing MMC repair. One, to monitor kind of the disease from the initial diagnosis till potential treatment, but also to really make sure that had the full discussion, have as informed of a consent as possible, with Dr. Badia's point being that certainly an at-risk population with pressure for intervention, for maternal guilt, but to try to be as mindful about that as possible and to do it where in a kind of systematic way as ethically as possible. So I think that multidisciplinary discussion is crucial, and one that was highlighted even in 1982 with the tenets that FMSS has published.
Yeah, well, we're right at time. I think